Whether breastfeeding or formula feeding, ensuring an infant is properly nourished can feel very stressful for parents. Add in sleep deprivation, constant diaper changes, and nonstop crying, and that's a recipe for one overwhelmed parent. The most common questions I get in clinic always revolve around infant feeding. My name is Colleen. I'm a pediatric PA and registered dietitian, and this is the Exam Room Nutrition Podcast, where each week I'm giving you answers to common nutrition questions to help you become a more confident, compassionate clinician. On today's episode, we're teaching you all about infant feeding so you can provide your parents with actionable strategies to help them feed their baby well. You'll learn the importance of oral assessment and why feeling for a latch isn't the only thing you should be checking for. We'll also show you the most effective feeding position, the difference between different bottle nipples and their flow rates, and if nipple confusion is actually a real thing. Plus, stick around to the end for my nutrition notes segment because I give you a refresher on infant growth rates and some red flags that you cannot miss. Now, since we're talking about growth, I also want you to know about a free resource I've created to help you interpret and explain growth charts to parents. So if you're new to pediatrics or you just want a script for what to say when explaining a growth chart, go to examroomnutrition.com/growth chart and download the guide for free. I am so thrilled to learn from Mallory Roberts today. She is a speech-language pathologist and infant craniosacral therapist. She's the owner of The Feeding Mom, where she provides parents with virtual feeding support around the world. Her specialties include infant reflux, oral and body dysfunctions, including tongue ties and bottle feeding. Mallory, thank you so much for being here. I can't wait to get into this topic. Welcome to the show.
Hi, thank you for having me. I'm excited to be here.
I am just so thrilled to actually meet you sort of face to face. And I've followed you for a while on Instagram. So I just absolutely love your content as a pediatric PA. The things that you provide are so useful and I had to have you on. So my first question for you is, what should clinicians be looking for if the parent says that their child is struggling to take a bottle?
So from a clinician point of view, we have to start with watching baby eat, right? A lot of times I'm getting babies for second, third opinions, and nobody's actually watched baby eat. They sort of look at baby, maybe they good in their mouth, they listen to the history, and then they make some judgments. So really watching baby gives you a lot of insight into what's going on, even the setup of the feed and how the feeding starts. So a parent comes and says, I'm struggling. Watching baby, getting inside of the mouth. Don't just look in the mouth, feel inside the mouth, and then connect that to what the body is doing. What is their body telling you about their feet? Are they frustrated? Are they relaxed? Are they holding tension from their body? But then also pay attention to the parent. The parent gets missed in that relationship so often, and they are a huge piece of the puzzle. So watching how tense the parent is during the feed, how are they holding themselves? What is their energy towards the baby during the feed? Are they like hyper fixated on them taking the bottle or the breast? You can figure out a lot about the whole dynamic.
I bet you most clinicians aren't doing any of that. So we need to be observing the baby feed, putting your fingers in their mouth and feeling around, making sure that there's not any oral issues going on, and watching the parent. I mean, that right there is so powerful, so helpful. So what are some different bottle feeding positions? Because I know a lot of us know that cradle hold, but there are other ones. And I think this is a really helpful thing for you to walk us through. Let's say we've observed mom feed and the baby's actually, a little bit uncomfortable. What are some different positions that we can suggest mom to try?
So I'm always an advocate for an elevated sideline position. And I've pulled it from research done on NICU babies. And when we're giving that kind of position, we are allowing baby control. And I don't know why we don't want to give that control to all babies. And then taking also positions from a breastfeeding perspective. So I've sort of combined the two. And I really, really push for the sideline position to become more universal. In the cradle position, we talk about how baby doesn't have control of the feed and they're not getting that jaw movement that we want them to have. A lot of times parents are missing fullness cues because they're in that cradle and baby's having trouble showing them that they're done. And so an elevated side lying is always a goal for me. As baby gets older, typically they move into an more upright position, right? But there's lots of ways you can do an elevated side lying. And so you can start, especially in the newborn phase. And I know parents who keep this position, but if you are leaned back and they're just sort of on your chest, right? And you can hold bottle here. So we're doing a side lying. They're elevated, they're side lying. Their jaw is allowed to move forward. When they're done, they can clearly tell you they're done, right? They can move away from the bottle. We're not putting any pressure on their skull or their jaw like we are when they're in cradle, okay? And so this position, a lot of parents love, especially for the newborn phase. They like to be snuggled up to that chest anyway. And so they're usually in that position pretty commonly. The other way we can is if you're in cradle, a lot of parents who have been doing cradle, we can just simply turn them. Okay. And so now at least we're giving them that jaw movement. We're giving them that ability to control. We're giving us the ability to help pace if baby needs that. But a lot of parents say, I feel so disconnected, right? Because baby's looking out from you. Yeah. And so the next way you can do that is to have your knees out in front of you, elevated, and then baby is out sitting on your knees. Okay. You can use a pillow, whatever's comfortable for you. Some parents like the nursing pillows and they sort of rest them on the nursing pillow and feed the bottle this way. And a lot of times I get people who say, well, how do I know if they're in an elevated side lie? And really, you want to be able to see the jaw come forward. If they're too far, if they're too far in cradle, their jaw will move downward. It will have trouble coming forward on the bottle. We want to see that. We want to see as less amount of contact here and on the jaw, right? To allow for that movement. And we want baby to be able to tell us that they're full. So we need them to be able to move some way. When you're working with parents who have been cradle feeding, that's really comfortable for them. Sometimes it's as simple as saying, okay, can we just start by elevating them a bit? Okay. Because then at least we're allowing some jaw movement and we're allowing parents to pay attention to them and their fullness cues a little more. And then parents can get more comfortable with really moving them into a better position. So it can be hard on the parent to change something that they're really ingrained to do, right? So sometimes it's just easy, simple transitions that you can make really big change with.
I love that too as a pediatric PA because you're taking the baby off the back of their head. So now you're repositioning. So if we've got a kiddo who's got plagiocephaly or brachycephaly, now we're also repositioning them to help with that flat spot too. So I really love that elevated side lying position. If you guys are listening on podcast, check out a clip of this on my Instagram page at Exam Room Nutrition. And Mallory has tons of videos on her page that show you exactly how to do this. But I think it's a really, really great position for so many different reasons. So I do want to kind of circle back a little bit to something you said in the beginning. You talked about the importance of evaluating and watching the baby feed and then evaluating their mouth and putting our fingers in there and looking around in there. What are we looking for? And what are we feeling for?
So many times we know, okay, let's latch, right? You see that all the time. Therapists, any kind of provider will go in and feel the latch. What's interesting is whenever I hear, wow, their latch is really strong, my brain does not go to, well, that's good. My brain says, wow, I want to feel around more and make sure that that's not tension related. So many times when I feel a strong suck, it's that they latch on, but they have no movement with that latch. So you can have a really strong, tight latch because that tongue is a muscle and it's going to try to, it latches. But feeding is more than just the latch. It's the coordination of it. It's the movement. It's the synchronicity with the breath, right? And so I want you to feel the muscles. Are they moving well? Because if it's just kind of stuck there and you pull your finger and it's just sitting there latched on, then we want to feel around for more. I want to know where the cheeks are. Can we move the cheeks? Are they so tight that there's no movement? I want to go under the tongue because that's where the muscles are anchoring down, right? And so can you get your finger underneath the tongue? Does it elevate enough for you to get into that space? Then, of course, we're feeling the palate. Does it feel high and narrow? That would suggest that the tongue is not sitting where it's supposed to be sitting most of the time. And then what impact does that have on latch, right? So that's what we're looking at in the mouth when we talk about watching baby within the body. What are the shoulders doing? Are they fisted hand the whole time? Are they really squirming on their bottom end, right? Feet curled in. Do they stay just curled in and they just look? Are they scrunched up in the face? Or do we have this hyper tense baby just with a strong latch, just trying to hang on and survive?
I love that. And again, I bet you most of my listeners that are clinicians and work with infants aren't doing all of those things because they probably weren't taught that. You're like, look for a tongue tie and feel the latch. And if they're doing that and everything looks good. So I think those are really, really important that you need to be doing in your physical exam. So this moves us on nicely to the concept of oral play. So I'm curious if you can explain what that is and if we should be teaching our parents to do this with their baby.
So role play is a hill I will stand on forever, right? Because it's just so important. And it's really important for us to understand that oral play is not wound care. We are not holding baby down and doing exercises to prevent scar tissue buildup, right? We are not doing these post-surgery. Oral play is meant to be engaging. And so if you're with a client and they are super oral defensive, that tells us a lot about their acceptance, their sensory system, what may be going on in the mouth. And oral play is how we can improve and relax that system when you do it correctly. And so for those babies, we have to work within the body first. We have to work with the outside of the face, work with their nervous system to calm them, and then accept. If we are doing oral play and baby is screaming and baby is uncomfortable, it's not play. Then we're just forcing movement and creating more tension in the body. So I have to say that because there's a lot of hate on oral play. And I believe it's because a lot of clinicians are not taught how to do oral play correctly. And we're holding baby down, getting in the mouth, thinking that we're doing these oral movements. And it's really counterproductive if they're fighting it. Well, on the flip side of that, what can oral play do, right? It allows the movements of the mouth. It allows baby to recognize and release whatever they're holding on to. Once they can release that tension, movement improves. Once movement improves, or you're in there and you're touching areas of the mouth that maybe the tongue can't do yet, right? Then we're improving oral mapping. And what does that do? It decreases the gag response. It helps with oral acceptance. And so I believe all babies would benefit from oral play. And they do it naturally, right? They put their hands in their mouth. They're taking things on the floor and mouthing things from a therapy perspective and to really get into the muscles. That's where oral play comes in because they can grab a teether and mouth it all the time, right? But when you engage the muscles in a specific way, you're allowing for different movement that they may not reach themselves.
Now, is this something you would suggest general pediatricians would teach parents? Or if we're even considering oral play, should we be referring to people like you, speech language pathologists?
Yeah, I think that anybody can teach it. It's just engagement with your baby in a different way. It's sort of like tummy time. If there's a dysfunction, that's where the assessment comes in, right? If pediatricians are teaching this, yeah, beautiful. I also think it increases the parents' awareness of maybe something's going on and maybe wrong and reach out for more help because then they're aware. Now we're drawing awareness to potential oral dysfunction And that's where the therapist comes in. The parents aren't assessing, right? They don't know the muscles of the oral mechanism and exactly what each of them are supposed to be doing. And so that's where the therapist role comes in.
And so for some of my listeners who might be like, what the heck is oral play? Can you explain that in a way that they can explain it to their parents and kind of demonstrate or show them what it is and what the parents could be doing?
So oral play is getting in the mouth and you are giving specific input to facilitate better movement. From a parent's perspective, if you're just wanting to give parents something to start with, we're going to go in the mouth and we're going to rub all the way back to the gum line, come around to the other side, all the way back to where the baby's molars are going to come in eventually. And you're going to do the top of the gum line too. And what parents should be seeing is that the tongue follows the finger. Okay. That's your first step into what you want the tongue to be doing in terms of awareness and movement. What I find is that many times babies who are carrying tension for whatever reason in the mouth, when parents go into that back gum line, their tongue sits low and stays in the middle and they sort of just munch, right? Now, munching is a reflex when you touch the gum line. So that's not a huge thing, except you want to see the tongue moving. So if the tongue's not moving and following, then that's where we need to start.
As general pediatricians, we are not the experts per se in this specific issue. So these are just some really great tools to be instructing your parents and for you to be assessing your patients with. But if there is any issue with tongue movement or feeding beyond your capacity, this is why I do this podcast. This is why I want you to refer to specialists who can further help their patients. Mallory, I want to linger with bottle feeding a little bit more before we jump into breastfeeding issues. And I want to talk about bottle nipples and flow rates because I have a lot of questions from parents and they're like, well, what bottle do I use? And which nipple am I supposed to use? So can you just give us kind of like a baby bottle 101 and the different flow rates and when are we supposed to use the different nipples for which age group?
Okay. So you have three basic types of nipples. You have your standard narrow nipple. What the Dr. Brown bottle is, it's what your like off-brand bottles. If you go to Walgreens, they're standard narrow nipple. And then you have what we call wide neck. Now, wide neck can vary a little bit, but essentially it's a long nipple. And then you get to a point where it expands out into this wider piece. Okay. A lot of times, well, probably even just a couple of years ago, and they still advertise them as this. These bottles are what you're going to see on the box that say most breast-like or whatever the marketing is. And I will also say that there is no regulation on bottle companies, meaning they can say whatever they want to say about any of their nipple shapes or how they flow or their structure. There's no regulation, which goes into flow rates too, because there's no regulation for those as well. A one on one bottle is not the same flow as a one on another bottle. So that just makes everything much harder, right? But then we have this newer, not so new anymore, but this is your sloping nipple. So it slopes into a wide. So you have your standard that's narrow. You have your wide neck, which is long nipple and then goes wide, but your sloping slopes to wide. And what that does is it helps create a better latch because baby can sort of flow to it versus like running into it on a wide. And that makes more sense when you can see what I'm saying. But if they're latching and they just run into the wideness, right, versus being able to flow on the wide, it can really help latch. This is really good for when we're talking about like filling that palate space too. So then we get into flow rate. Flow rate is all marketing as well. They're not age determined. A baby who tolerates a 1 at birth and becomes efficient on a level 1 should stay on a level 1 their whole feeding journey. They become more efficient. So instead of 1 suck, swallow, breathe, they become more efficient and do 2 sucks and then 3 sucks, right? And so efficiency improves. When we're increasing flow rate, I like to think that bottles came out with that for babies who need thickener for dysphagia purposes. And then it sort of just blew up into this age range thing. Or maybe they created the ages just for marketing and selling more products, but who knows, right? But if you have a baby who needs a thicker formula for dysphagia, then we're looking at a faster flow. If you have a baby who's breastfeeding from a parent who has an oversupply, then they may start at a level 2, right? Because they're becoming efficient on a really fast flow at the breast. And so they'll need a fast flow on the bottle, and they just stay with that throughout their full journey. It's not necessary for babies to move up as they get older. Oftentimes, I think that's how oral dysfunction gets missed, because we're just taking away that suck efficiency, and we're giving them, it's just pouring in their mouth at some point. I mean, when you go to a 2, it just flows out. There's no need for them to have a good suck and latch. And so level 1 is what I recommend, unless we're looking at other variables, but we would start that from the beginning anyway.
That was so interesting. And I actually did not know that the flow rate wasn't standardized. I didn't know that. So I want to link you here a little bit, just so my listeners are clear and have a really good understanding of flow rates, because these questions come up all the time. So if an infant starts on a 1 and they're feeding and doing well, they can stay on a 1 until they transition over to sippy cups and open cups, correct?
For sure. Oftentimes what happens, and what's interesting, is that level 2s are marketed about 3 plus, right? And around 3 or 4 months, you have a really big growth spurt. And a lot of times they're just having to relearn. Maybe they're carrying some tension in their mouth, right? And so we just need to do some movement with them. We need to allow time for them to reorganize and adjust with that big growth that just happened. But oftentimes that is the age where they are told, well, just bump up in the flow. And so then we're just like, well, you didn't really facilitate. You made it easier for them.
Yeah. And I love that you explained that, because it makes perfect sense as to if they aren't latching and sucking well on a 1, going up to a 2 is not going to strengthen their muscles or improve their tension at all. You're just making the flow come out easier. So you're not correcting the main problem. So this was such an excellent explanation. Thank you for just bringing so much knowledge to us today. So I want to end out this segment by talking about breastfeeding and addressing some of the concerns with breastfeeding, which is a huge, huge topic. But give us just some really good touch points that we can talk to our parents about when the infant is having some difficulty latching or feeding on the breast.
So this is definitely lactation consultant territory, right? And so I am not a lactation consultant, but I work with a lot of lactation consultants. And what I will say is, it's not, and this goes with bottle feeding, right? This is about the assessment piece and getting in the mouth. It's not always about what latch looks like from the outside. So lips look good. They're taking in a lot of the nipple, and you're like, well, it looks good. Doesn't mean that it is good. That we can't see what the tongue is doing. And sometimes if the tongue is really just sitting low and has no movement, you won't even hear the clicking part. It won't even be reaching the palate to click, right? And so when we're talking about listening to the parent and they're coming to you with concerns, we need to look inside the baby's mouth, and we need to understand what the muscles are doing before we can say, well, it looks all right. So taking the baby's perspective and then watching the whole dyad. Sometimes it's positioning, right? And you just need to pull baby down a bit, and that helps. Sometimes it's just a little bit of tension in the mouth, and maybe they just need help opening a little wider, activating that tongue muscle before feeds, and then they're more efficient at the breast. What frustrates me the most is that most of the time we say, well, it looks good. There's nothing else we can do. Why don't you try bottles? And it's like, well, that's not really the answer. That's like moving up flow rates on the bottle, because we're not finding out the answer to why they can't be efficient on a level 1, right? So it's just the equivalent. We keep passing up, looking into what's going on and making it easier.
Now, what are your thoughts on either a nipple shield or putting like a baby bottle nipple over the breast? I've kind of heard this recommendation sometimes for babies who maybe the mother's breast milk is like really, really quick, or she's in pain, or there's some other issues latching. What are your thoughts on using either of those two methods?
I think they're great as transitions. So while it's wonderful to get baby on the breast and it helps the success of breastfeeding, that is a transitional method. So we need to be working with someone specifically trained in that to get them off of the nipple shield. We shouldn't be using that for months and months on end.
Yep, great point. And I really love that you respect other professions, right? I mean, lactation consultants are the experts at breastfeeding, and you are the expert with bottle feeding. So I love that it is interdisciplinary and that, it's okay that we aren't really proficient at all things infant feeding. That's why we can refer out. So I hope my clinicians are really understanding what their role is in this and that it is perfectly fine and appropriate to refer to either a lactation consultant, a speech language pathologist who is really well trained in infant feeding. Now, I wanted to ask another question about nipples, specifically breastfeeding and bottle feeding, because I also have a lot of patients who do both, right? They'll do the breast for a little bit, or they'll alternate breast and bottle feeding. And I'm curious as to your thoughts with nipple confusion. Is this a real thing? And if so, how do we address it?
So, not nipple confusion, it's nipple preference, right? And so, when we look at the semantics of that, because essentially it's just a word change, right? From confusion to preference. But really, for the parent to understand, I think that word is important because when we say confusion, what we're offering is that babies can't learn both. And that's not true. When we say preference, what parents are hearing is, okay, what can I do to change the preference or make it more even or help them establish both feedings? And that's where we really get into matching mom's flow rate. And usually it's going to be a slow flow or even an ultra slow because baby has to work to get the milk in the beginning, right, of a breastfeed. And then taking baby out of cradle so that we're not just allowing milk to drip in the mouth. If a baby has to work at the breast really, really hard, and then we're putting them in cradle with the bottle and it's just dripping in and they don't have to do anything, I prefer it that way too.
Right?
Who wouldn't prefer less work to get the same outcome? And so by taking them into a sideline position and having them latch on to the bottle just like they would a breast instead of putting it in their mouth and then just having it drip in, right? So now we're allowing that latch. We're allowing the tongue to sit where it's supposed to sit, for the lips to flange like we want on the breast, for the head and jaw to move in the same way, right? And then we talk about, well, what happens when they pause? Well, when we're in this elevated sideline position, if the bottle is horizontal, when they pause, it's not dripping out continuously, right? We can even lower and maybe give them a pause and a break when they're just learning how to regulate that flow. Okay. And so parents who are doing both need to understand that baby is absolutely not confused and they can learn both and they can do both efficiently. We are the ones who are taking that efficiency away because of the way we traditionally bottle feed.
I love your use of words and how words matter and the definition matters. I talk about this all the time, that it's important for clinicians to be defining the word the same as the parent. All right. So I love to close out my interviews by asking the expert what your worst piece of advice that you've ever either heard, from a parent or in your experience that a clinician has said regarding feeding that makes you cringe and you're like, please stop this madness.
I mean, how much time do we have? No,
Right?
I'm just kidding. I guess the worst thing, the thing that makes me cringe the most is when a parent is having feeding difficulties and they are told, well, baby's gaining weight, so everything is fine. That's probably my biggest one. That is the biggest gaslighting phrase for anyone who's struggling to just hear, well, what you are seeing and what you are feeling does not matter because baby's gaining weight and weight is the only thing that matters. And weight is not the only thing that matters. When there's dysfunction in the mouth, there can be breathing dysfunction. There's digestion dysfunction. There's regulation dysfunction. So just because mom has a fast flow or baby is taking 4 ounces out of the bottle because mom is feeding them every 30 minutes to an hour just to get the ounces in, that is not okay. And weight is not the only thing that matters.
I love that suggestion because I do hear that a lot too. And I think, I'll take the clinician side of that. I think that's an easy thing to reassure parents because really 90% of our job is to just reassure nervous parents. And it's an easy way to do it. Hey, look at their growth chart. They're gaining weight really well. You're okay. You can do this. And I hear it a lot with reflux too. It's like, okay, well, the baby's spitting all over all of your clothes and it's a mess and your car's messy and the car seat stinks. But it's okay. They're gaining weight when, like you said, it really just undermines the parents' concerns and it invalidates all of their issues and stressors and concerns that they're having with feeding their child. So what a fantastic piece of advice that was. Mallory, thank you so much for being here. I learned so much from you, and I really know my listeners just are like on the edge of their seats wanting more from you. So can you tell us where they can find you, where they can hang out with you on social media?
So I am on Instagram the most at infant.feeding.specialist. I post so much information there.
Amazing. So we're going to link up to all of that down in the show notes below. Mallory, thank you so much for being here. We would love to have you back. I can't give you this gift of your time back. So thank you so much for spending it with us today.
No, thank you for having me.
All right, guys, now it's time for my nutrition notes. So today, let's talk about infant growth, specifically weight gain. As a reminder, infants should be doubling their birth weight by 6 months of age and triple it by 1. It's expected that newborns will lose some weight in the first 5 to 7 days of life. A 5% weight loss is considered normal for a formula-fed infant, and even up to 7 to 10% weight loss is considered normal for breastfed babies. But it is vital that the baby has regained that lost weight by 10 to 14 days of age, or in other words, they need to be back up to their birth weight by 2 weeks of age. So how much weight should the baby be gaining? So during the first 3 months, we should see about 1 ounce or 28 grams of weight gain in a day, or that would look like 5 to 7 ounces a week. That weight gain will slow at around 4 months of age to about half an ounce or 20 grams a day. And as they turn 6 months old, many babies are gaining about 10 grams or less a day. So what are some red flags I want you to know about? Number 1, if the baby hasn't regained its birth weight by 2 weeks of age, red flag. Number 2, if the baby doesn't gain about an ounce a day or 30 grams a day in those first 3 months, red flag. Or if the baby doesn't gain about half an ounce, actually it's 0.67 ounces or 20 grams a day between 3 and 6 months of age, red flag. So in these cases, you need to ask specific questions regarding the formula, how the parents are making it, how many ounces the baby is taking per feeding, how often they're giving a bottle, if the baby is feeding at all during the night or if they're just sleeping all night long, how many poopy and pee-pee diapers the baby is having, and you need to actually observe the baby feed, just as Mallory had suggested. If you found value in today's show, I would love if you could share this episode with a colleague. It is my goal and true passion to educate clinicians to be more confident and effective with their nutrition recommendations. You can show me some love by leaving a 5-star rating or even writing a fabulous review. Thanks so much for being here and listening to my podcast. As always, let's continue to make our patients healthier, one exam room at a time. I'll see you next time.